Hey everyone. I hope you all are studying up for the exam and are taking it. You'll have until Halloween to finish it, so about a week and a half. Um, if you do have any questions about the exam or the study guide, please don't hesitate to email me. I'm happy to help. Today we're going to discuss personality disorders, which is chapter 10. Don't worry, this is not on exam. Obviously, if you've gone through the study guide, this will be on the last exam. So people with personality disorders have inflexible and maladaptive traits that are pervasive and stable. Their ways of thinking, perceiving, and behaving compromise their ability to function effectively and relate to other people in the environment. They experience chronic interpersonal difficulties, problems with identity or sense of self, and are unable to function in an adaptive manner. People with mild personality disorders may function adequately, but would be described by others as difficult, eccentric, and hard to get to know. So today we're going to discuss 3 clusters of personality disorders, along with psychopathy. So the general features that characterize personality disorders include chronic interpersonal difficulties, problems with one's identity or sense of self, as we discussed a bit before, and an inability to function well in society. So in order for a personality disorder to be diagnosed, a person's enduring pattern of behavior must be pervasive and inflexible, as well as stable and long in duration. So a lot of these disorders develop early in childhood or I mean, later in childhood, early in adolescence, and last throughout the lifespan. It must also cause either clinically significant distress or impairment in functioning and be manifested in at least 2 of the following areas: cognition, affectivity, interpersonal functioning, or impulse control. The DSM-5 personality disorders are grouped into 3 clusters. Cluster A, which consists of paranoid, schizoid, and schizotypal personality disorders. Cluster B, which consists of histrionic, narcissistic, antisocial, and borderline personality disorders. And cluster C, which consists of avoidant, dependent, and obsessive compulsive personality disorders. There are substantial limitations to the category and cluster designations that we'll kind of discuss throughout the lecture. So, several epidemiological studies have assessed the prevalence of personality disorders. The overall prevalence estimates tend to be remarkably similar, where between 10% and 12% of people meet the criteria for at least one personality disorder, when the time period being asked about the person's behaviors over the last 2 to 5 years. There are distinct difficulties in diagnosing personality disorders. The diagnostic criteria are not as sharply defined as they are for most other diagnostic categories. Criteria for personality disorders are defined by inferred traits or consistent patterns of behavior rather than one or more objective behavioral standard. Although semi-structured interviews and self-report injuries have been developed, diagnostic reliability and validity is still pretty low. Competing conventional views like the 5-factor model, which is the most influential model of personality disorder, which we'll talk about in a little bit, kind of sees these as extremes in behavior or normal behavior. Many of the difficulties with personality disorders stem from difficulties in studying the causes of personality disorders because they're hard to study and diagnose because they're very comorbid with other disorders. It's hard to really, like, if it's on a spectrum of normal personality, where do we draw that line into abnormality? So there's also little prospective research on disorders too. It's also a very relatively new area of study. So the dominant model of personality is the 5-factor model. It is basically consists of 5 factors of personality: neuroticism, extroversion, openness to experience, agreeableness, and conscientiousness. You can also order that to spell ocean, if that's easier to remember. These are also on a continuum between extremes of that type of behavior. So it's like opposite. So neuroticism and kind of well-adapted behavior, or like introversion and extroversion. That's a better example of a different polar extremes of those types of traits. Personality disorders are considered extreme aspects of the 5 factors. So where you have like negative affectivity, that's an extreme of neuroticism. Detachment is extreme introversion. Antagonism is extremely low agreeableness, and disinhibition is extremely low conscientiousness. Okay, so now we're going to discuss each personality disorder in each of the clusters, starting with cluster A. So paranoid personality disorder is the first one we'll discuss. Individuals with this disorder are suspicious, they distrust others, they bear grudges, they refuse to forgive perceived insults or slights. They can display violent behaviors, rigidity, hypersensitivity, and argumentativeness. The person is constantly on guard for attacks from others. The prevalence is around 1 to 2%, with equal numbers of men and women being affected. Causal factors for paranoid personality disorder are not very clear. It's not very well studied. There have been inconsistent findings on genetic transmission. However, heritability of high levels of antagonism and neuroticism is associated with it. Psychosocial causal factors are suspected, such as parental neglect, abuse, and exposure to violent adults. Schizoid personality disorder has not been the focus of much research attention. The central symptoms are an inability to form social relationships and indifference towards developing them. When considering the symptoms in terms of the 5-factor model, we see individuals with extremely high levels of introversion and being low on openness to feelings and achievement striving. Early theorists believe that this was a precursor to psychotic illness. There has been some link to autism spectrum disorders for schizoid personality disorder. Severe disruption in sociability seen in schizoid personality disorder may be due to severe impairment in underlying affiliative systems. Schizotypal personality disorder is associated with extreme introversion, sensitivity, and eccentricity. There are pervasive social and interpersonal deficits, oddities and eccentricities in communication and behaviors, and other cognitive problems like ideas of reference, odd speech, and paranoid beliefs. Causal factors are believed to be moderately heritable with a genetic and biological association with schizophrenia. I think that's obvious from some of the symptoms here that look very much like schizophrenia. Individuals are likely to have a history of childhood abuse and trauma. Interestingly, they have the ability to track, they have inability to track a moving target. They have attentional deficits, deficits in working memory, and deficits in the ability to inhibit attention to a second stimulus following the presentation of the first stimulus. So there's not a lot of flexibility in cognitive switching. Okay, so now moving on to cluster B disorders. These are more of the extremes in emotionality. So we'll start with histrionic personality disorder. Histrionic personality disorder is a disorder associated with a high and changing levels of emotionality. It's associated with excessive attention seeking. Individuals with this disorder have highly unstable interpersonal relationships. They're often self-centered, vain, and overly concerned about approval. They have a tendency to be sexually provocative and may attempt to control partners through seductive behavior and emotional manipulation. The prevalence in the general population is a little over 1%, although some believe rates of this disorder may be decreasing. There's a possible genetic link with antisocial personality disorder. Maladaptive schemas revolve around the need for attention to validate self-worth. There's been little research conducted due to the difficulty in differentiating this from other personality disorders. It's highly comorbid with borderline, antisocial, narcissistic, and dependent personality disorder diagnoses. And this is likely because of the overlap in personality traits between all of those disorders. It involves extreme versions of extroversion and neuroticism and a strong need for attention to validate sense of self-worth. Narcissistic personality disorder is associated with an exaggerated sense of self-importance, a preoccupation with being admired, and a lack of empathy for the feelings of others. There are two subtypes, grandiose and vulnerable. Narcissistic personality disorder is more common among men than women. Fragile and unstable self-esteem underlies grandiosity. Individuals are inclined to be hypercritical and retaliatory if the desired validation or assistance is not achieved or received. Causal factors for grandiose narcissism most likely include parent over-evaluation, and for vulnerable narcissism, they're most likely emotional, physical, and sexual abuse or intrusive controlling and cold parenting. People with antisocial personality disorder persistently violate the rights of others through a combination of deceitful, aggressive, and antisocial patterns. Intelligence and charm can be found in many antisocial personalities. People with this disorder show disregard for the rights of others in a pattern of irresponsibility. To be diagnosed by age 15, there must be evidence of such things such as like repeated unlawful behavior, deceitfulness, impulsivity, aggressiveness, or consistent irresponsibility in work or financial matters. The prevalence in the general population are around 2 to 3%, and it's more common in men than in women. Antisocial personality disorder is often interchangeably used with psychopathy, but they're not the same thing. Using concordance method and adoption methods of research, results show a moderate heritability for antisocial and criminal behavior. Other causal factors include having low family income, living in the inner city, having poor supervision by parents, having a young mother, being raised in a single parent home, having conflict between parents, having a delinquent sibling, neglect, a large family size, or harsh discipline from parents. The relationship between antisocial behavior and substance abuse is sufficiently strong. Antisocial personality disorder has roots in childhood. The number of especially for boys, the number of antisocial behaviors exhibited in childhood is the single best predictor of who will develop an adult diagnosis of antisocial personality disorder. And often ADHD is a precursor of adult antisocial personality disorder. So borderline personality disorder is one of the most well-researched form of personality pathology. It is characterized by great suffering on the part of the patients themselves. The pattern of behavior is characterized by impulsivity and instability in their interpersonal relationships, their self-image, and their mood. There is a great deal of affective instability as well. Individuals have a highly unstable self-image or sense of self. They tend to have chronic feelings of emptiness and a difficulty forming a sense of who they really are. They struggle with negative self-concept and find it difficult being alone. They engage in impulsive self-destructive behaviors such as gambling, binge eating, substance abuse, and reckless driving. Borderline personality disorder is also associated with self-mutilation, and repetitive cutting behaviors. In community samples, only almost 1/4 of people diagnosed with the disorder report that they've made at least one suicide attempt. In clinical samples, that rate is around 35%. Estimates are around 1 to 2% of the population might qualify for a diagnosis of borderline personality disorder, and approximately 75% of individuals receiving this diagnosis in a clinical setting are women. It tends to be comorbid with disorders such as mood and anxiety disorders, as well as substance abuse. There's substantial co-occurrence with other personality disorders, especially schizotypal, narcissistic, and dependent personality disorders, as well as histrionic because of that unstable affectivity. The risk of having a borderline personality disorder diagnosis is found to be 4 times higher in biological relatives of patients with the disorder than it was in relatives of people who did not have a diagnosis of the disorder. Genes may account for up to 40% of the variance in this disorder. Research to date largely focuses on candidate genes related to the serotonin system. 2 genome-wide association studies also published. The results of these studies have been pretty disappointing because there hasn't been really any conclusive findings. Environmental factors are thought to account for the largest proportion, up to 55% of the variance in these traits, with childhood maltreatment and other extreme early life traumatic experiences being linked to developing the disorder. As we know, early life trauma may create long-term dysregulations of the hypothalamic pituitary adrenal axis and shape brain development. So that could also be a system that's dysregulated with borderline. Neuroimaging studies suggest that borderline is associated with increased amygdala activation in emotion-inducing situations, as well as reduced prefrontal regulation, which is likely why you see more amygdala reactivity, because the prefrontal areas aren't stopping it from being reactive. There's a movie out there, which a bunch of y'all have probably seen, called Girl Interrupted, which discusses borderline personality disorder, or at least has a character in the movie with borderline. It's also a really, really good book too. Okay, moving on to cluster C. So we'll start with avoidant personality disorder. People with avoidant personality disorder fear rejection and show extreme social inhibition, introversion, and hypersensitivity. They desire affection, are lonely. They desire interpersonal contact, but avoid it out of fear of rejection. Some hypothesize that avoidant personality disorder is more extreme, like more of an extreme form of generalized social phobia. A twin study in Norway found a modest genetic influence with genetic vulnerability at least partially shared with that of social phobia. There is a genetically and biologically based inhibited temperament associated with the disorder. Another causal factor might be emotional abuse, rejection, or humiliation from parents who are not particularly affectionate. Abuse and rejection lead to anxious and fearful attachment patterns, and introversion and neuroticism are also elevated in this disorder. If you hear a lot of snorting, I apologize. That is my dog. He has allergies. So individuals with dependent personality disorder show an extreme need to be taken care of, which leads to clinging and submissive behavior. They show acute fear at the possibility of separation or sometimes of simply being alone. They may be indiscriminate in their selection of mates. They may accept abuse in order to remain in a relationship. It is more common in women than in men, which may be due to a higher prevalence of neuroticism and agreeableness in women. It is often comorbid with mood disorders, anxiety disorders, eating disorders, and somatic symptom disorders. Causal factors include authoritarian and overprotective parents and maladaptive schemas about weakness, incompetence, and needing others to survive. Obsessive compulsive personality disorder is associated with perfectionism and excessive concern with maintaining order and control. Mental and interpersonal control is maintained. Individuals repeatedly check work for mistakes. It's much like OCD. However, unlike people with OCD, those with obsessive compulsive personality disorder don't have a true obsession or compulsion ritual. It's slightly more common in men than in women. Some features overlap with narcissistic, antisocial, and schizoid personality disorders. Using the 5-factor dimensional approach, individuals have excessively high levels of conscientiousness, devotion to work, assertiveness, perfectionism, and excessive controlling behavior, and a low level of compliance. The biological dimensional approach indicates that individuals have low levels of novelty seeking, reward dependence, and harm avoidance, but high levels of harm avoidance. Sorry. Okay. So in general, personality disorders are difficult to treat. They represent relatively enduring, pervasive, and inflexible patterns of behavior. This might be due to varied goals, a client's resistance to change, having relationship formation challenges, and really there's just not been a lot of studies done on treating personality disorders outside of borderline personality disorder. Possible goals of therapy include reducing subjective distress, changing specific dysfunctional behaviors, and changing whole patterns of behaviors or an entire structure of the personality, which is extremely difficult. I mean, personality, there are some, personality is pretty standard and maintained throughout the lifespan. So this is likely why a lot of therapies are hard and clients or patients don't buy in. Unfortunately, many people with personality disorders come to therapy only at the request of someone else, which means they might not be as invested in the therapy. Also, many people with personality disorders, especially those in cluster A or B, will have difficulty forming a therapeutic relationship, which then makes keeping those individuals in therapy that much harder. Therapeutic techniques can be adapted to treat specific personality disorders. Therapists need to be careful not to encourage dependence, particularly with borderline and histrionic personality disorders. Acting out behavior may need to be constrained. Specific therapeutic techniques are essential to the cognitive approach to personality disorders. Techniques include monitoring automatic thoughts, challenging faulty logic, and assigning behavioral tasks in order to challenge a patient's dysfunctional beliefs. Treatments for borderline personality disorder are the most studied. The first type of therapy is dialectical behavior therapy, or DBT. It combines individual and group components as well as phone coaching. It is a form of cognitive behavioral treatment that is problem-focused and based on a clear hierarchy of goals. These goals prioritize decreasing suicidal and self-injurious behaviors and increasing coping skills. The patient learns interpersonal effectiveness, emotional regulation, and distress tolerance skills. And phone coaching helps the patient identify and change problematic behavior patterns and apply newly learned skills effectively. Also, a variant of psychodynamic therapy is sometimes used. The primary goal is strengthening weak egos. The focus on primary defense mechanism of splitting is also used. Biological treatments include the use of drugs, but there's little evidence to support the use of drugs. Antidepressant medication, most often from the SSRI category, are most appropriately used when the patients also have comorbid depressive symptoms. Some second-generation antipsychotic medications and mood stabilizers may slightly reduce symptoms, but only over the short term. These aren't things that should be used over a long term because they're not as effective unless there's a comorbid disorder that these medications also treat. Often cluster A and B disorders are typically treated with antipsychotic medications. As you saw, especially with schizotypal, you see a lot of psychotic symptoms. They only have a modest success, especially with schizotypal, for which it's typically prescribed. Antidepressants from the SSRI category may also be useful. There's been no systematic controlled studies of treating people with either medication or psychotherapy for paranoid, schizoid, narcissistic, or histrionic disorders. Cluster C disorders fare well with active and confrontational short-term therapies. They also show significant gains with cognitive behavioral treatment. Antidepressants from the MAOI or SSRI categories may also be helpful in conjunction with other types of therapies, especially in the treatment of avoidant personality disorder. Okay. So now we're going to talk about psychopathy. Psychopathy is kind of a personality disorder. It's not really a DSM diagnosed personality disorder, and a lot of people try to use it as antisocial personality disorder, but they're not the same. Psychopathy was formerly called sociopathic personality disorder. So you might hear people referring to psychopathy as sociopathy, or psychopaths as sociopaths. Sociopaths, that's kind of an outdated term. Now in clinical research, we use the term psychopathy. I can't stress enough that it's not the same as antipersonal personality disorder, even though they are very similar. The prevalence of psychopathy isn't really known in the general population, but it's about 1% that we think. In the prison population, it sits around 30%. It's more common in men than in women, just like antisocial. However, there's not a lot of research looking at differences between men and women. It's associated with inadequate conscious development and irresponsible and impulsive behavior. Individuals with psychopathic personality traits take rather than earn what they want. They're prone to thrill-seeking and deviant and unconventional behavior. It's associated with high rates of alcohol abuse and dependence and other substance and dependence disorder as a whole. However, when you start to break down psychopathy into different types of personality factors, you might see differences in the abuse of substances there and some of these different types of behaviors, which I'll kind of break down in a minute. Elevated rates of suicide attempts and completed suicides are only associated with interpersonal affective dimensions of psychopathy. Individuals with psychopathy have the ability to impress and exploit others. They are superficially charming and likable. They have good insight into other people's needs and weaknesses and are highly adept at exploiting other people based on those. They're frequent liars and can easily win friends, but seldom keep close friends. So there are 4 dimensions of psychopathy: interpersonal, affective, lifestyle, and antisocial. Lifestyle and antisocial dimensions are more closely related to the DSM diagnosis of antisocial personality disorder than the interpersonal affective dimensions are. So we have a psychopathy lab on campus. That's where I did my dissertation work. And we break psychopathy into two orthogonal factors: fearless dominance and impulsive antisociality. So impulsive antisociality looks more like antisocial personality disorder, where fearless dominance looks more like those charismatic, typical psychopaths you see displayed in the media. So that would be more interpersonal and affective dimensions, where you see that superficially charming. However, both factors associated with psychopathy are associated with things like risk taking and trauma exposure. However, things like impulsive antisociality, or this more closely related to antisocial personality disorder personality traits, you see that if more associated with comorbid disorders like anxiety or higher symptoms of post-traumatic stress disorder, rather than fearless dominance, which is not associated with psychopathy in any, or psychopathology in any ways. So when comparisons have been made in prison settings to determine what percentage of prison inmates qualify for a diagnosis of psychopathy versus antisocial personality disorder, typically found that about 70 to 80% qualify for a diagnosis of antisocial personality disorder, but only about 25 to 30% meet the criteria for psychopathy. When you look at psychopathy broken into impulsive antisociality and fearless dominance, you see impulsive antisociality more associated with criminal recidivism than you do with fearless dominance. So many researchers use the Cleckley-Hare psychopathy diagnosis rather than the DSM antisocial personality disorder diagnosis. So the diagnosis of psychopathy appears to be the single best predictor of violence and recidivism. However, that's when you use a dual factor modeling Cleckley and Hare's breakdown of psychopathy and the traits associated with it. A diagnosis of antisocial personality disorder may be omitting those who do not show violent behavior. Okay, so moving on to some of the causal factors of psychopathy. Several studies show that psychopathy and some of its important features show considerable heritability. A twin study of 3,687 twin pairs at age 7 found that the early signs of callous unemotional traits in these children were highly heritable. Based on a study of over 1,000 twins, it has been estimated that 43 and 56% of the variance of the dimensions of psychopathy is attributable to genetic factors, and the remaining variance is explained more by non-shared environmental influences rather than shared environmental factors. Low fear and impaired fear conditioning may explain some of the risk-taking behaviors associated with psychopathy. Psychopaths high on the dimensions of the first factor of the PCLR, which is the psychopathic psychopathy checklist revised. So those are more associated with fearless dominant, impersonal affective types of behaviors. Show poor conditioning of fear. Lycan found that psychopaths show deficient conditioning of skin conductance responses when anticipating an unpleasant or painful event, and they were slow at learning to stop responding in order to avoid punishment. Psychopaths presumably fail to acquire many of the conditioned reactions essential to normal passive avoidance of punishment, to conscious development and to socialization. Patrick and colleagues found that psychopaths show deficient fear potentiated startle. And I also was able to kind of replicate some of these findings in my dissertation study, looking at social support and fear conditioning in individuals with higher in fearless dominant and impulsive antisocial traits. So Newman and colleagues showed that people with psychopathy have an excessive focus on reward. This may interfere with their ability to use punishment or other contextual cues or information to modulate their behavior. Psychopaths have a deficient ability to modulate their attention, developing something akin to tunnel vision in their single-minded pursuit of their goal. There are also more general emotional deficits, for example, a reduced responsiveness to aversive visual images consistent with findings that they are low on empathy. Small startle responses when viewing unpleasant images may also be related to a lack of empathy as well as dysfunction in the amygdala. Early parental loss, parental rejection, and inconsistencies is also a causal factor, or are also causal factors. In addition to genetic factors and emotional deficits, slow conscious development and high levels of reactive and instrumental aggression are influenced by damaging effects of parental rejection, abuse, and neglect accompanied by inconsistent discipline. However, these kinds of disturbances alone are not sufficient causal agents. Frick and colleagues showed that there are at least two different dimensions of children's difficult temperament that lead to the development of different developmental outcomes. Some children have great difficulty learning to regulate their emotions and show high levels of emotional reactivity, including aggressiveness and antisocial behaviors when they're responding to stressful demands and negative emotions like frustration and anger. These children are at an increased risk for developing antisocial personality disorder and high scores on antisocial dimension of psychopathy. Sorry. Other children may have few problems regulating negative emotions instead of showing fearlessness and low anxiety, as well as callous unemotional traits, and reduced amygdala activation while responding to fearful facial expressions. They're more likely to show poor development of consciousness if they do respond in that way. Aggressive behaviors are more instrumental and premeditated rather than reactive, as seen with those children who have emotional regulation difficulties. They're more likely to develop high test scores on interpersonal affective core of psychopathy, so that fearless dominant type of traits. And this leads to cold, remorseless psychopaths who show low fear and a lack of empathy. Treatment of psychopathy is really hard because psychopaths experience little personal distress and don't believe that they need treatment, which is one reason why this isn't really a personality disorder per se, because it doesn't cause them distress, and they don't really see if they, especially successful psychopaths, which are those who are more fearless dominant, they don't really have many problems getting what they want and kind of surviving. Impulsive antisocial individuals do have more problems in those domains and may seek treatment for other types of things. Punishment for their behavior is generally ineffective. A few studies have found that treatments that work for other criminal offenders can actually be harmful for psychopaths, especially in the rates of reoffending increase rather than decrease in that population. Biological treatments have not systematically been studied, but even if medications were effective, individuals generally have little motivation to take their medications because they don't see any problem with how they are acting. Common targets are increased self-control, self-critical thinking, and social perspective taking. Increasing victim awareness, teaching anger management, changing antisocial attitudes, and treating drug addiction may also be helpful. However, interventions require a controlled situation. Even the best programs produce only modest changes, although they are somewhat more effective in treating young offenders rather than older offenders. Treatments may be useful in reducing inmates' antisocial behavior in prison or other forensic settings. However, results tend not to generalize to the real world if the person is released. Though many antisocial personalities do not show or they do show improvement as they age, and actually many of the personality disorders in general show improvement as they age. This may be related to weaker biological drives. Individuals achieve insight into their self-defeating actions over time, which is likely also related to aging. Most likely also the cumulative effects of social conditioning over time. Only the antisocial behavioral dimension of psychopathy seems to diminish with age. The eccentric, callous, and exploitative, affective, and interpersonal dimensions persist. And that's likely because that's rewarding over time. And they don't have that much social conditioning then with those types of behaviors. Okie dokie. So that is all I have for today. Feel free to email me any questions you have, and I look forward to presenting to you next week. Take care.